Good evening. I would like to welcome you all to another important podcast on a very important topic, which is very relevant today. And Yashoda Hospital conducts these webcasts every week. And the important topic that we have taken up today is the long distance ECMO transport and where the real barriers we face when we are transporting patients from long distances. And the barriers that we face today are going to be discussed by Dr. Ravi Krishna, who is our critical care consultant here in Yashoda Hospital, Somaji Guda. To talk on this very important topic, we are joined by an elite expert panelist, Dr. Ramanathan sir. He needs no introduction. He's a pioneer in the field of ECMO, and we are glad to have him joining. He's a adjunct associate professor in cardiothoracic ICU from the National University of Singapore. We welcome you, sir, to the webinar today. And we are also joined with an esteemed faculty, Dr. Himal Dev, who is the Chief Consultant Critical Care at Apollo Hospitals, Sheshadripuram, Bangalore. Welcome, Dr. Himal. And to take forward today's podcast discussion, we have Dr. Ravi Krishna, who is an ECMO physician here with us at Yashoda Hospital, Somaji Guda. So today we'll be discussing about a case scenario where we got a call from a long distance within the boundaries of Indian territory, where we had to pick up the patient in a dire situation and we had to bring him back to Hyderabad at our place. And what are the difficulties that we face when we are transporting ECMO from such huge distances? So I will give over the case presentation to Dr. Ravi Krishna. And Dr. Ravi Krishna, can you take over from here?
I hope my slides are visible, sir.
Yes, they are visible.
Right. Yeah, thank you for the wonderful introduction. And I hope I can address few of the doubts and the panelists can help us discuss about this topic further. So without further ado, I would like to start with what actually happened regarding a case scenario. So it was a late Sunday evening when we probably had a call that we may get a call for an ECMO retrieval. Then at 1 o'clock, the patient's family actually wanted to get their relative transferred to our hospital. So this call was from Guwahati, which was roughly around 1800 kilometers from our hospital. And there were a few tricky situations which we faced during this retrieval. So I'll discuss them as we go along with this case. So regarding the case, he was a 28-year-old guy who had met with a motor vehicle accident close to his home. And on evaluation with a polytrauma protocol, he was found a traumatic brain injury with grade 1 to 2 diffuse axonal injury with a left high frontal intracerebral hemorrhage. Initially, he had a GCS of around E1, VT, M5 with splenic lacerations, bilateral lung contusions with a right femur fracture and a left tibia fracture. Initially, at presentation, he had mild ARDS at the time of admission. Gradually, he developed into moderate to severe ARDS. He initially was managed medically, but post fixation of his right femur fracture, his hypoxia continued to deteriorate. Because of his condition, he was initiated on VV ECMO with heparin as an anticoagulation. The initial 1 to 4 days, he was having a smooth ECMO run. On day 5, he developed mild oral bleed. So day 6, they found that there was a slight worsening of hypoxia even on ECMO, and on evaluation, there was found to be a left moderate pleural effusion, for which tube thoracostomy was. On that day was normal, but the next day, they found that it was converted into a left hemothorax. Around 1.1 liter of serosanguinous to hemorrhagic fluid was drained, and he required around 3 PRBs of transfusion. So when we actually received the call, the patient who was not initially in shock was in shock with a norepinephrine requirement of around 0.5 milligram per kg per minute with a MAP of 90 millimeters of mercury, hemoglobin of 7.4 grams with a fibrinogen of around 156 milligram per deciliter, and with the platelets of around 1,20,000. The family wanted to referred to our hospital, and they were eager so that they don't want to waste any time. So, coming to the questions. So this question is for Ramanathan sir. So what criteria do you use to determine whether the patient is suitable for a long distance transfer?
Yeah, thanks, Ravi. Look, it's an interesting case you presented, but if I were to generalize as to who should be transported, I would clearly think of two main indications or two main factors. One, patient indications. So is this patient a candidate for an ECMO? And the second component I would think is the logistic component. Does this patient benefit by transferring to my center? Will I be able to offer something more? So let's say that patient doesn't have an ECMO service in the peripheral hospital that refers the patient to you, and I have to go and retrieve it. Yeah, I can offer ECMO services. I'll get it in here. But if the referral center already has an ECMO setup, what am I going to gain if I'm going to transfer? Am I going to offer something which is not there in that hospital, say cardiothoracic or surgical services, or something like transplant services? Then there is a need to transfer these patients out of a peripheral hospital. At the patient indication side of things, I would think it's more or less quite similar to assessing any patient candidacy for ECMO. I would definitely give more importance to his ongoing hemodynamic status, because in your case here, this polytrauma patient was bleeding. So sometimes, preliminary or primary decompressive surgeries or surgeries to contain bleeding might have to be done before you even depart. So these things would definitely run through my mind as to whether this patient has uncontrolled hemorrhage, whether clearly, there is an indication for ECMO altogether or ECMO transfer altogether, whether my center can offer higher services to this patient. And of course, last but not the least, I also will have to make sure that my ECMO capacity is not running at its maximum. So logistically, I should have ECMO trained people at my center with enough beds to accommodate such a patient. So this would be the thing, main thought process about ECMO transport from my side. The one thing I forgot to tell you, probably it might impact on your long distance transport would be weather. So clearly, if weather is not congenial, you might have to plan your transport accordingly when weather clears.
Yes, sir. So like you have already said, most of the time the patients are usually transferred because they need access to advanced procedures which are probably not available at the local site, or they are being worked up for cardiac transplant or lung transplant, which is obviously not possible at all the centers which do ECMO, or patient's family wants to transfer to a high volume center because of probably significantly better outcomes at the site of transfer. So whenever we transfer a patient, we must always understand that it is the sickest patients who are the ones who usually don't tolerate this long distance transfer. And Sir, Dr. Himaldev, sir, this question is for you, sir. What are the common reasons for declining ECMO transfer requests?
Okay, thanks, Ravi. I think, first, congratulations on that case, what you have retrieved. It's a very challenging case, and you've done a fantastic, job getting him there. So, in line with Dr. Ramanathan, sir, the main reason is in this patient is a case of traumatic brain injury. We'll go with this patient recommendation only. If it is an irreversible neurological damage, and suppose that could be one of the deterrent where the possibility of this man coming out will be very less. So offering him an ECMO becomes challenge because you're going to, send your best of the teams to the ECMO transfer. Here at your hospital, the other patients can get jeopardize their quality of safety. The second one is, there will be a lot of pressure from the primary treating team there, or from the family who are desperate to get the patient the best of the benefits. But you need to assess them whether this patient really benefits from all this transfer, because the cost is also humongous for this transfer. So you need to really know whether this patient is a candidate. Since your traumatic brain injury level was not so severe, his GCS was within a moderate to traumatic brain injury, probably he's okay. But if it was a severe traumatic brain injury or probably irreversible brain injury, then probably he's not a good candidate at all. Or if there's a irreversible disease like a terminal malignancy or multiple organ involvement, and as rightly pointed out, if there is a major hemorrhage which is ongoing, which is uncontrolled, then those patients are not probably a good candidates for transfer. You need to stabilize them. Otherwise, there will be an exsanguination during the transfer and the patient will collapse there. And one more thing is, if any patient like yours had a prolonged cardiac arrest and a prolonged CPR and unknown neurological states, that also could be one of the possibility where you should not offer them ECMO there. And other things are common. It's already a delayed escalation, like not in this case. Any other cases, if there is a prolonged ventilation for more than 7 days and the feasibility of ECMO is not good, then again there should not be you should not offer them. Then routine contraindications, like if there is no referral center capability, of course we should never do it. And if you're not capable to do the transfer, we should never offer them. And some of the scoring systems, like your RESP score and SAVE score systems, in your case it is a VV ECMO, so it's a RESP score system that will prognosticate, and that can guide you whether this patient's survival is going to be good once you retrieve them to your center. Because it doesn't end with the transfer. You need to look at the patient after transfer, whether he'll recover from that and go home. That is the main aim. Just transferring is not the ultimate thing. So looking at all those things, major contraindications is irreversible injuries and irreversible disease and multi-organ injury, ongoing instability. So the patient is severely acidotic and patient has exsanguinating hemorrhage, then better not to venture into that unless the patient gets a stability. So this would be some of the major reasons for declining an ECMO transfer request.
I think Ramanathan sir and you have covered almost all the possible reasons why we have to probably decline a patient's transfer. So just a few additions to it. Like Ramanathan sir has already pointed, every transfer, especially those which require air transfer, require a lot of resources, not only in the terms of manpower, but also financial resources and nursing resources. All of this using for a patient who has very less chance of survival is probably taking these resources away from a patient would probably benefit with these resources. An ECMO physician looking after 3 patients in his own center, getting transferred to another center to retrieve these patients probably puts his own patient at his risk. And we should also accept that any transport team member who has to possibly face the not so good consequence of an in-transit death or circuit failures or circuit emergencies during transport develop significant traumatic stress disorder, and they also eventually develop compassion fatigue. So because of this, all transports probably need a lot of debriefing and psychological care before they embark on long distance transfers. So coming to our case, so our hospital has decided that we would retrieve the patient. So an ECMO retrieval team was formed. Since the patient was already on ECMO, our team consisted of an ECMO physician and a perfusionist. And because the airport was a military airport and there are not of frequent flights between Hyderabad and Guwahati, we used a piggyback ride from Hyderabad to Guwahati via Agartala. So we could reach there by around 12:30. The flight, the nearest air ambulance was near Kolkata. So the air ambulance left from Kolkata to Guwahati and we would join them in Guwahati. So coming to, sir, this question is for you, Ramanathan sir. How do you prepare for retrieval from a remote location or hospitals with extremely limited infrastructure?
Well, I think again, this question will have multiple components to it. Um, if I have to summarize it in broad headings, as part of preparation, you need to have the right team to transfer. You need to choose the right vehicle or right mode of transfer. And clearly, when you say limited infrastructure, you need to anticipate or at least get a prior handover as to what is available and what is not available in the referral hospital. And sometimes you might even have to carry a few things with you as part of logistics. So in terms of team, of course, for long transfers, long distance transfers, or especially air transfers, a minimum of 3 people in a team is required, and of which one will be the ECMO lead, which will usually be the physician. There will be 2 ECMO specialists, and the third person is usually a coordinator who will make sure that your arrival and other things are coordinated well. As part of preparation before you leave, as I said, you take a good handover and decide on how you're going to do it at that hospital. I think the best way to prepare your team and yourself is to at least, think through the fact that you will get very minimal help. So as much as possible, carry your, equipment wise, you definitely will be carrying all your ECMO machines and other things. But in addition to that, you might have to carry your own pumps, you'll have to carry the emergency drugs and all those stuff. So again, like any other transfer, you'll have to think through all this. And again, this will also be dependent on the second fact, which is the mode of transfer. So if your mode of transfer is going to be on the road by ambulance, I think you need to prepare yourself as to, if it is a say 6-hour drive, you might have to think through that situation, and you have to think through additional catastrophes such as what happens if the ambulance breaks down. What are the hospitals en route where if you have to stop by for something or the other, say an oxygen cylinder, which are the hospitals en route? And if there are people whom you know there, just give them a heads up saying that I'll be passing by just in case. And I think, these would be the important considerations when you transfer somebody from a remote location. The other usual minor aspects, again, even though it is minor, it can be very crucial at times. Spare batteries for the machine, for the ventilator, for whatever equipments you are carrying, the plug points and the ability to charge en route. Again, with air transfers, you can have changes in altitude and pressure that can alter your measurement of your blood gases. Or in this patient, you had a hemothorax. I'm sure it would have been a hemopneumothorax. So all these things would matter when you prepare yourself for such transfers.
Sure. I think, as you rightly pointed out, sir, even the also mandates that at least a minimum of 2 trained ECMO specialists, probably ideally 3 for air transport is required. Should include a physician and an ECMO specialist who would either a perfusist or a critical care nurse who's trained in ECMO, a third critical care nurse, and a 4th person who would coordinate regarding the logistics, especially regarding the route planning, emergency backup planning with regards to blood products, oxygen, power supplies, and to coordinate with the transport crew regarding the weight and space allocation within the flight. So Dr. Himalya, so this question is for you. How do you choose a transport mode?
Yeah. Yes, Dr. Ravi. So the transport mode depends upon the distance also, where the referral call came from, and also the accessibility, whether it can be reachable on road or we have to go fly and retrieve the patient. But generally, it is by the distance. And probably the easiest and the most convenient way is the road transfer, that is by our ground ambulance team. So generally, any distance which is less than 200 kilometers can be easily covered by ground ambulance. Sometimes it goes beyond certain, if there is a proper highway and there is a strict traffic control, then you can reach for a higher distance also. But still higher, the longer distance or non-accessible areas, like if it is more than 500 to 1,000 kilometers ranges, it's usually we use a fixed wing aircraft. So that's an modality which we use, and it has its own problems. If you have a ground ambulance, the space and all those things are much better than what you use in a fixed wing aircraft, which is more cramped up. And the power supply, which is the commonest concern, for this transfer, it's better in the ambulance compared to our fixed wing aircrafts. And altitude concern, what Dr. Ramanathan said, may not be a major concern in this ambulance part, because fixed wing aircrafts, as the atmospheric pressure goes lower, there are chances of all these problems. The gas expansion, as you rightly said, there can be a expansion of pneumothorax. Not only that, even if the endotracheal tube cuff, it can inflate too much, so it can cause necrosis of the tracheal wall as well. And sometimes there can be a microembolism. So those challenges are not there in this ambulance transfer. Again, you don't have to depend on the weather per se, so that could not be that could be an advantage here in the ground transfer. And as I told you, the working space is much better. And there is another modality called as a rotary wing, that is helicopter transfer also is being done. And that is also done for a longer distance, somewhere between 400 to 800 kilometers distance. And again, the accessibility where there is no proper landing airports. So, but the problem with this here is also there's a problem with the power supply, altitude, everything is there. But one more problem with this is there is a vibration effect, so it can affect a lot of component problems, and sometimes even the clots at the sites of cannulation can get dislodged and cause bleeding later on because of the vibration. So these are some of the problems which can happen with these. So this is for a feasible transfer less than 300 kilometers. I think ground ambulance should be good, but fixed wing aircrafts will have their own challenges, and that has to be carefully addressed before we jump into these thing. Fixed wing aircrafts, one other problem is the temperature. There will be a profound heat loss, and that requires a strict monitoring. You need to use the ECMO temperature. Also, sometimes you need to wrap the patients very well so that there will be profound heat loss and cause problems later. So these are the commonest modalities used and their advantages and disadvantages. We'll not go too much into their other logistics, like how do we go into the airport and all those things that we can probably discuss later on. These are basic ones.
Yes, these are very important points what Dr. Himal had actually told us. But I just have one question, Dr. Himal. Like we often face the number of people that are allowed into these. We usually get air ambulances which are turboprops. Like we have one perfusionist, one ECMO physician, and we need ECMO nurse. So at the max, we can take 3 people, but they also says that there should be 2 ECMO specialists there. So in your real life experience, like what are the number of people that are allowed when you are airlifting these patients, and how do you accommodate them, or how do you adjust your responsibilities appropriately?
So as you rightly said, I think 3 is what is generally allowed. Otherwise, more than 3, there will be a lot of problems there. And sometimes even the family members wants to join, accompany the patient during the transfer. So you imagine the trouble there.
Yes.
But I think an ECMO physician will be a team lead there. I think that is, and ECMO specialist actually can help us with the other ECMO component. And a nurse should be good enough. Generally, that is what we follow here. So that is how we go and retrieve this thing. And I think
3 members.
that should suffice.
Team.
3 members should be. 3 members is what generally done. If at all an extra thing, then probably we have to coordinate with the local team there and get somebody there over there, and then help us with, especially if we need a surgeon backhand. So a surgeon flies separately, or he we have a local person who can help us with that. That is how we troubleshoot things.
Yeah, Ravi, you can continue. Yeah. So we have the next question to Dr. Ramanathan. Like, how do you manage equipment, sir? Like, we have had a brief discussion when Dr. Himal was talking about the kind of batteries that you need to take and the kind of equipment numbers that you have to restrict, especially, the permissions and all that it takes when you're crossing airports, and the batteries need some biomedical clearance also when you're carrying these equipment. So how do you manage your equipment when you're carrying them on the aircraft, like especially when you're retrieving the patients?
Yeah, it's also a very challenging problem, because on one side you're already dealing with a sick patient, and then you have to worry about other things like equipments also in long distance transfers. It's an additional responsibility, and that's where I feel role clarity in the team should be very important. The person who is arranging the logistics, the coordinator, should take the lead in this, making sure that clearances are obtained or appropriate people are contacted. Now, provided that these administrative things are taken care of, you also will have to focus on how you maintain or manage this equipment during use. Of course, during transport, we expect that there will not be much of damage, and most retrieval teams have a standardized retrieval baggage, which is used, so the baggage can be different for air ambulance versus fixed wing. For the fixed wing, it will be more. When it is standardized in terms of cannulas, in terms of circuit, in terms of the ECMO, oxygenator, and the pump, it becomes a lot more easier. The only thing when it comes to long distance transfer would be the fact, and if it is going to be in a really a peripheral or a rural area or the outback, you will have to consider some of these equipments in additional numbers, say an additional cannula, an additional circuit, and all those stuff. So clearly, taking the baggage to the peripheral hospital can be standardized in many ways. Once the patient is on ECMO, I think the challenges are slightly more different. With limited resources, you'll have to now plan your transfer back with the equipment as well as the patient. So here it has to be very coordinated, and if teams have not done transport in the past or not trained in ECMO transport, this can lead to mishaps. The usual kind of mishaps that we get to hear, especially with road ambulance transfers, forget all the road traffic accidents and all those things, are mainly related to handling the patient during the transfer with the ECMO machine. Need to understand that some of the ambulance drivers are not trained in ECMO transfers. They just come to just transfer the patient, and when they offer a lending hand, of course, their intention is to help you, but sometimes they don't get some of these aspects right. We've had patients who have fallen off their
Stretchers, yeah.
And they have had subdural hemorrhage thereafter. It becomes really a tough time to then handle not just the patient, but also the relatives. And I understand that, sometimes the very objective of transferring the patient gets lost.
It gets lost, yes.
By such accidents. Yeah, these are freak accidents, but then that essentially happens when you deviate from the protocol or deviate from your standard practice in some way or the other, or in the moment of, panic, or in the moment of urgency, when you try to deviate, compromise, these things happen. So such things are avoidable, things during transport. So it all boils down to how you get the patient and the machine as a compact package, and how you minimize movement between the patient and the machine, that eventually, will boil down to a safe transfer. Mind you, it's easy for me to say that. You'll also have to make sure that you have adequate ports
Yes.
for resuscitation,
Yes.
for giving fluids, for giving infusions. And clearly, there are ways of doing it. So to me, the best way to get adept at this is by simulation training. So when you
Yes.
train your team, have at least a few sessions on how you're going to do this. And if it involves, say, multiple transfers, say, from hospital to airport by ambulance, and then from airport to the other airport by fixed aircraft, and thereafter by ambulance, you may want to simulate at least parts of this trip before you actually do it. We've done it many times, especially when it comes to looking at some of our reaction time. So at Singapore, the Ministry of Health essentially audits our reaction time to ECMO referral. So from the point I get the referral to the point I accept the patient, and thereafter the clock starts ticking, my team will have to reach the peripheral hospital within a prescribed time. And the hospitals are placed such that you would be able to reach there. And if you go through Google Maps or any map device, the distance and the timing at the peak time and the least peak time are looked at, and the average is taken, and you're expected to keep to such timelines. Otherwise, you'll have to answer such questions as well. But then, it may not be practical in every scenario. And there is more to do with how you set it up in an urgent referral scenario. And we are essentially tuned to that right now. In a place like India, definitely this is going to be decided not just by your reaction time. It's also going to be dependent on how your traffic is, how the weather is, and all those stuff. So clearly, it may be impractical. But clearly, these things come into play when you transfer your patient on ECMO.
Yeah. Yes, sir. Totally agree with you. I think that's a valid point. Like simulation is the key. That's how you bring down your reaction time, as well as you prepare yourself better when you're traveling with these patients. Yeah, Ravi?
You need to have a backup,
Yes,
and you need to have a backup for the backup.
yes.
So
Redundancy plan should be there.
yeah, so I'll just tell you a scenario which happened. We were actually transporting a patient on road via ambulance. There was a neighboring city, that was Shimoga, probably around 250 kilometers from here. And patient was initiated on ECMO there and got her in the ambulance. But she had so much of polyuria and she had a lot of volume loss. We had certain number of IV fluids, but it was not enough. And at a point of time, she had such a low blood pressure, so it was almost impending. This usually happens in case of certain patients we have seen, like pressure natriuresis. If the cannula is near the renal artery, they have a lot of solute diuresis and they pour out a lot of urine. And the ambulance had to be stopped at two places to get the IV fluids, and again replace the volume and get to Apollo. So that's why sometimes whatever we take may not be enough. So we need to have a backup plan. And as you said, the Google locations are different hospitals on the way. So if in case somewhere I fail, I need to have a backup, and also ambulance backup also. Sometimes we take 2 ambulances because one breaks down. One had happened when we were retrieving somebody from Mysore, and so the other set of people come in another ambulance, so it will be a backup ambulance. So these are all things, probably a small challenges which we faced. Yeah.
Yeah, Ravi, would you continue with your case? Yeah.
So I think Dr. Himaldev and Dr. Ramnath sir are adequately covered regarding the minimum number of people required and regarding the how to choose a transport mode. So coming back to our case, we reached Guwahati around 12:30 p.m. and assessed the patient by 1 p.m. The patient was under sedation with a MAP of 80 with a NORAD requirement of around 0.4 mics per kg per minute. The ICD column movement was adequate and there was no active drain when we saw the patient. He was on an ECMO flows of around 3.8 liter per minute in a femoral drainage and a jugular return with a sweep of around 4 liters with an effort requirement of 0.8. The patient's family was counseled about the risks involved in transfer and agreed for the airlift.
Yeah. So this comes to a very important question again, like how do you prepare your circuit emergency? These are something that are dreaded complications that can occur, and you don't want yourself in such a situation. So if you face one, how do you like prepare for that kind of emergency, Dr. Himal?
Yeah, Karthik, so I was always thinking, we think distance is a problem. Distance is not the main problem here. I think the preparedness and the patient itself, the patient selection is very, very important. And unfortunately, if the patient is very sick or if the patient has circuit related problems, then it becomes a difficult situation. So as I discussed before, the right briefing is very, very important. In the sense, if there is a problem, we need to brief the pilots saying that if there is such a problem, this should be a emergency landing option somewhere here. So we need to have a backup plan there. So again, if we discuss, there are like in the transit, suppose if it is air transfer, it can be a patient problem. You have to be prepared. Like you can have a hemodynamic collapse, or they can have a desaturation. So accordingly, you need to have a backup vasopressors and volume uh, replacement. And if there is an oxygenation drop, you need to see what is the cause for that. If it is the lung issue per se, if it's an oxygenation issue, and then we have to tackle it. And again, you need to have this all vasopressors, antiarrhythmics if there is any arrhythmia there, and you have to tackle that. That's a patient problem. I think most of the times you'll be able to tackle that. But the real problem happens when there is a circuit issues, So you need to have a constant monitoring of oxygenator delta pressures. And oxygenator suddenly won't fail. It will give you a hint. And if you calculate in such a way that you can reach the destination, it's okay, we can manage them. Otherwise, you need to instruct them to have a emergency landing somewhere, and probably we need to change the oxygenator. But we'll have a backup oxygenator always. As I told you, backup to backup. So that is one thing. Second one is, unfortunately, if there is another circuit problem like air embolism, again, that can be a big problem there. So there also not much of a thing. You need to follow all the air embolism protocol, clamp the circuit, try to de-air the circuit, give the proper head and head position, reverse tendon position or durance position. And then again, instruct the pilot to take it down. And then if you're not able to successfully de-air that, then probably we have to get them to a emergency landing and correct it. The other problem is pump failure. This is what we need to be prepared for. And this has happened to one of our retrieval team. So where they had to hand crank for at least a duration of 45 minutes to 1 hour, as because there was a pump failure, and they had to, but somehow they were able to hold on till the patient had landed at the destination. And after landing, there was a change in the circuit, and the troubleshooting got better, and we could do this thing. But only thing is, the golden rule here is, if the emergency cannot be managed in the air, then you have to have an emergency diversion. You can't do all these circuit change there, or doing all that maneuvers. And as I rightly said, pilot must be briefed before the takeoff itself that this could be a problem which can arise in these patients, and we need to have the landing situations in these places.
Yeah, I totally agree.
Yeah.
And apart from circuit emergencies, this is a very, very important topic when you get a retrieval call. How you effectively communicate between the referee hospital, the retrieval team, the transport provider, and receiving center. So, at your place, how do you practice the communication art? Like, how are all the players in the loop? Like, what's going on? And, what is the time of arrival? How do you communicate in? I think Dr. Ramanathan has left for the day. I mean, he's caught up in some work. So, how do we have the communication channel running during the whole event of referral of the patient? How do you people do it?
Yeah. Am I audible, Dr. Karthik? There was some disturbance when you spoke. Dr. Ravi, can you hear me?
Yeah, you're audible, sir.
Okay. I think that was a very good question, Dr. Karthik. So, structured ECMO handover, that is what I would tell. And
Yes,
that's what we
I was
follow. It's
asked.
called,
Yeah,
yeah, I got the question. Thank you, Dr. Karthik. I heard you. Yeah. So we follow the same thing like S-bar protocol with what we used to follow in Australia. Also, the same protocol we do it here. See, one of the most or biggest preventable transport complication is not what we discussed, like air embolism or mechanical failure. Probably it is ineffective communication and lack of preparedness. And probably this can be curtailed if we can follow a proper handover. Like when we get the retrieval itself, probably we need to talk to a right person saying that is he really a candidate for an ECMO? And as I rightly said, there will be a lot of family pressure. They say, doctor, do everything, take him to your place, and somehow you need to make this patient
alive again.
survive.
Yeah.
And there's a lot of pressure from our team itself, our consultant saying that please get the patient, we'll do something. But I think you are the right person to decide whether is it risk going all the way there, risking our team, risking our resources, and also, yeah. So, and going there, and if there is a fatality, then there is no point in getting this patient. So if you can get the real indication and you feel the indication is right, then probably an effective communication, asking all the clinical details. Then once it is done, then our preparation, whether we are really equipped to go there, the team preparation, the equipment preparation, and also the transfer preparation. If it is done, a proper checklist has to be maintained always. Checklist will never fail you. So if once we do that, then probably the S bar is what is going to help us. Like once we retrieve back, as I told you, the transfer doesn't end with just the handover. You need to make sure that it has to be effectively communicated to all the our clinicians here, so that the continuity of the care will go on, and we can also tell us what are complications happened. For example, if you follow the S bar, when you go for that, you look at the S, that is situation. You have follow the patient demographics, what mode of ECMO patient is on, what is the duration of ECMO, and oxygenator, how long it has been there, and what is the indication primarily, and what is the course of trajectory from there, and background also, what was the history before, whether it is anticoagulated or not. In your case, there was a traumatic hemothorax and there was a ICD inserted. Was there any increase in bleed? And as we discussed, during these high altitude transfers, there can be a possibility that because the low atmospheric pressure, if there is a pneumothorax, then definitely there can be an expansion of this pneumothorax. There can be some minuscule air embolism if there is somewhere breakage in the oxygenator or some circuit. And yeah, and sometimes the PaO2s will be so low in these patients when they go into high altitude, you have to increase your FiO2. So whether these things happen during the transfer has to be effectively communicated. Will you be able to continue the anticoagulation that time, or did you withhold the anticoagulation? That has to be handed over. And also what happened to the flows of the ECMOs? Did the delta pressure increased? Oxygenator was not working very well. Was there any change in monitoring? Like during the beginning, what is the blood gas? And during the last part of the transfer, what is the blood gas? Hemodynamic states, vasopressor requirements, all those things are I'll cover under A part. So, and R part is the recommendation, like when is the next anticoagulation dose, or is there an urgent oxygenator requirement change? Do we have to do an urgent CT scan? Because we were not able to do a CT scan. And again, which are the specialists you need to get involved as soon as the patient comes? We can inform them beforehand so that they'll be ready and equipped so that the patient can get the best of the treatment as the patient arrives. At least minimum 10 minutes face-to-face handover is very, very important when we give the handover to the attending clinician here. I'll tell you one scenario. So we had retrieved one patient, young girl from a nearby city. The patient was status asthmaticus and she was on ventilator for a long time. And she was sedated, paralyzed. PCO2 was 112, 130 or something like that. And from last 24 to 48 hours, they were not able to assess the GCS because the patient was paralyzed. She was so stiffly, ventilation was very difficult. Nobody knew the neurological stage. Patient didn't have a cardiac arrest. So the only way we couldn't shift to the CT scan before initiating the ECMO because the patient was very unstable. We initiated the patient on ECMO. Patient was relatively okay after that. And we couldn't do the CT scan because some logistic issues in that particular hospital. We retrieved her to our hospital and all the parameters improved, but neurologically she didn't wake up and got a CT scan done. There was a massive hemorrhage everywhere. So I don't know, it's because of the high PCO2 levels or because of anticoagulation level, or was it because of, we actually went back and saw whether we reduced the PCO2 suddenly so that it caused so much of a pressure fluctuation and bleeding happened. But that didn't happen in that patient particularly. But if we had known that this patient had such a massive bleed prior to ECMO initiation, probably wouldn't have offered. So these are the logistical problems. If it is done at the right time and the handover is given at the right time, then we can avoid a lot of wastage of resources. And this
Right.
is how we can do a structured ECMO handover and avoid all the complications, human errors.
Yeah, well said, sir. I mean, apart from this, in this question, there is an aspect of how you identify yourself and to whom do you take handover from in a hospital where you're going for a retrieval, and
Yeah.
what's kind of help you require from the hospital per se there. So in these aspects, do you have any thing to say, like what is your protocols and what is your way of communicating with the hospital?
Correct. So in an ideal situation, if it is done in our place, we will have all the luxury. We have a cath lab, we have a transesophageal echocardiography probe, we have all that the point of care ACT machines. Everything is there here. So I'm going to a place unknown territory where I don't know whether on the phone I've heard the patient's clinical status and they have told patient is moderately built and nourished. But it's better to probably a video inspection of the patient before knowing how obese he is or whether the site is good for cannulation, so that I can be prepared. And if I require a surgical backup, we can get the surgical backup locally, or we can probably take our own surgical backup from here. Ask them whether they have a facility for cath lab. In case if there is a difficulty or a complication, we can definitely go there and cannulate them. A OT backup if there is a complication there. And yeah, that would be multiple levels of questions I would definitely ask them, and I prepare myself accordingly. And also, of course, um, the patient preparedness and the patient family's preparedness before going there. That is very, very important. Once I go there and patient says no, we have decided, and because the financial constraints or because of maybe they feel that the patient may not do very well, then it becomes a big exercise to take all these patients. So these are the ones we need to be cautious.
Yeah, true. Ravi, would you continue with your case? Ravi, you're not audible.
Yeah. Now I'm audible, sir? Yeah.
Yes.
Like you've already pointed out regarding the possible in-transit emergencies related to the patient and circuit, and when should we probably take a call to decide for an emergency landing with backup plans for the site of landing and all. And you are also covered regarding the proper SBAR handover, regarding the anticoagulation strategy, pre-ECMO initiation, and neurological status, his hemodynamics, and the plan for his initiation.
Yeah. So the physiological challenges during air transfers, we have almost covered most of them for the ECMO patients, and we've even covered this question of importance of simulation training for ECMO retrievals. So we'll skip these two questions and we'll go to the next slide, Ravi.
So we actually departed from Guwahati at around 8:30 p.m. to Hyderabad with a refueling stop at Bhubaneswar at around 12:20 a.m. In transit, power management challenge because of the long distance transport and lack of adequate power supply within the flight. We could manage it by carrying a backup Centrimac console. We also minimize the number of syringe pumps to bare minimal, double the dosage of drugs in each pump. We could land at Hyderabad at around 4:30 a.m. and we transferred him to a receiving hospital at 6 a.m.
So, Dr. Himal, I'm sure there are like developing countries have faced this problem of their capabilities of handling the patients with ECMO, and you have to have develop your capabilities, but also like maintain the safety parameters as well when you're traveling, transporting these patients. Like, how can like developing countries expand these ECMO transport capabilities and maintain safety? Like, what are the out of the real world experience? Like, can you like suggest any of interventions that you have seen or heard where you can like help people who are.
Yeah.
Dr. Himal, are you able to hear me? Yeah.
Yes. I got the question, Dr. Karthik. So there's a lot of challenges, So we are very brave and we are risk takers compared to the other countries. The safety is the one which probably is what we need to be um, uh, more careful about, and the second part is the local logistics. Like for example, if you look at the ground transport reality, again the NH the quality or the traffic quality, it's very variable, and there is always a lot of, as Dr. Ramanathan said, no, there can be a lot of. He said the patient fell down from the ambulance at an STH.
Stretcher,
Again,
yeah.
yeah, ambulance
Yeah.
drivers not very well. They think it is another regular patient, and they definitely will not use the follow that precautionary thing. And also we need to have the proper ambulances which can actually transfer the ECMO patients, which can actually accommodate these machines there, along with the oxygen cylinder, power backup, so that those can be developed better in case of ground transport. Because this the ambulance voltage and all will have 12 volts, but you require a higher volts up to 200 volts. So you need to have an inverter for that. So that can be probably, it's not a very expensive thing. So if you have an ECMO good capability center, you need to have that particular ambulance who can transport ECMOs. Night transport is a big concern because of a lot of traffic issues, erratic driving. And police escorts, it has improved significantly because our transfers here in Bangalore has been very good. Bangalore to Mysore or Bangalore to outskirts of the city has been very good. The police protocols have been pretty good, but compared to other areas, it needs to improve much more. There are a lot of traffic choke points. This is in terms of ground transport reality. But coming to the air transport issues, there is no dedicated air ambulance. We discussed about the fixed wing air transport, but you see hardly there are few which has the capability to give you that electrical supply. Not everyone has, so you need to have a good ECMO backup or probably 2 ECMO machines if you're going for a large transfer. Again, limited ECMO certified air ambulance fleets. Again, a lot of permission requirements, People sometimes requires a lot of explanation saying that this is a very sick patient.
Yeah.
I'm sure you would have experienced a lot of things in COVID, especially.
Yes.
A lot of restrictions there. But it has been easing out slowly.
Yes.
There's a lot of transfer which
Yeah.
has happened now. But compared to the West, we need to improve it. And how do we do it? Is probably by one is regular simulation and find out where are the problems are. Second one is in coordination with higher authorities. Involve a local uh, authority, who can take decisions on all these aviation control and help us for the ease of transfer. No need of prolonged checking there, and provide us
Yes.
with probably an equipped aviation plane so that we can transfer them. So regulatory and legal is a different ball game. There are a lot of things to be done there, but you require multiple level of meetings there and do that. And the last most important thing, Dr. Karthik and Dr. Ravi, is probably the cost is what is hindering the problem. Probably air ambulance transfer, I don't know what your structure is, but in us at least it takes from 5 to 15 lakhs, depending upon the distance, depending upon the sick patient, and depending upon the complications. The consumables also cost a lot there. And in the case of low middle income patients, it becomes a major barrier. And insurance is probably a big deterrent. I don't think the insurance is covered for the air transport. If I'm right, correct me if I'm wrong.
Yes.
Okay,
Yeah.
so
We don't have a reimbursement for the air transport. Yeah. They have to
and
shell it out of their pocket.
correct. And there are a couple of doctors who have asked us in case when they're going for a transfer, something happens to the patient in middle of the transfer. So who is going to be responsible for that? So all those complications, ethics is still under a lot of scrutiny, and people are discussing and people are trying to make some recommendation, but a long way to go. And but cost can be a big deterrent, and not everybody can afford that. So these are some of the
Yeah.
barriers and some of the changes which we can do in order to improve the air transfer or a ground transfer.
Yeah, but we have touched upon all those topics very, very eloquently, Dr. Himal. I totally agree. Like preparedness, infrastructure, and training or simulation, and you need to have awareness in the community level about these transfers, and the documentary process needs to be eased up, so that will expand the horizons in our country, definitely. Yeah, what protocols can we make for these safer transfers and make them more accessible? I'm sure, like we have touched upon the protocols of how you prepare for an ECMO checklist, and what protocols you make for the safety of the patients, your protocols for anticoagulation, protocols of documentation of vitals. Like, are there any other protocols that you follow during these ECMO retrievals, apart from your handover protocols and your such things, like anything that we have missed so far?
You have covered up everything because you've done a excellent transfer recently. But one thing is a consent. I think the consent is very, very must. It has to be explained in detail that possible complications. We should tell them that it is a bridge to whatever we are doing. It's a bridge to recovery or a bridge to a transplant. It has to be clearly mentioned because once they come over here, there should not be any arguments later on. So the consent part is what it should be a part of the protocol. As you rightly said, checklist is one important thing. Other than that, I don't think anything else is there. I think you have told everything else. So yeah.
Even the protocols for your identification, like or authorization from your hospital to the other respective hospital, and your communication, these are like never talked about things, but yes, when you get into problem, these preparedness also helps. Like what, how do you communicate, and how do you make sure that your responsibility are shared between the caregivers and the caretakers there? I think those protocols also need to be in place when you are starting off your journey on ECMO retrievals.
Yeah. And Dr.
Yeah.
Karthik, one more thing is you need to have a good coordinator with you whenever you're going.
Yes.
You can train
Yes.
your nurse itself or one of your team member. Because I've seen if you try to retrieve a patient from another hospital, a lot of challenges there. Patient is not discharged. Who pays for the an extra complication or anything there, of the patient is discharged and you put an ECMO there. So many logistical issues. If there is a clear communication from the coordinator, from our hospital and their hospital, that becomes very easy, so that we can concentrate clinical issues and the coordinator handles. So your role allocation is very, very important. That's what I want to tell you. Clearly allocate the role so that you don't go and put your hands everywhere and ultimately we fail miserably. One situation, Dr. Karthik, if I have 2 minutes, I'll tell you. One miscommunication which can lead to a problem is, like, suppose the simplest one. So patient was being retrieved from other hospital, and we got here. The only thing is, the patient was getting a cardio help machine with the HLS circuit, and we had a rotoflow machine where the exchange of circuit doesn't happen. So if at all they had told, we could have gathered a cardio help machine somewhere else and be prepared. So that becomes another challenge. So these are the simple things. There are so many, but I think these are the ones which I thought highlight so that we don't face. At least we know what are the challenges.
Sure. Ravi, would you continue with your case?
Yes. So I think, like, you already highlighted the major barriers which we face for transfer in India. We don't have regulations regarding proper air transfer protocols. We don't have protection for the doctors. We don't have insurance for the physicians who do airlifts for the air transfers, and the major costs incurred during transfers.
So I'm sure there is a scope for improvement, and innovations will definitely help us in making these retrievals safer and more accessible. Like, what do you foresee, Dr. Himal, in future? Like, any changes in the equipment, any changes in the modes of transport, or any changes in the way we deal with it, communication? What innovations you are seeing in your future which will make ECMO retrievals more feasible and safer to do?
Yeah. So I think the best thing is to do as much compatible and miniaturization of whatever we have. Cardio Help has already done it. If you have used Cardio Help machine, it's one of the best machine for the transfer, more stable. And it is commercially available, and it is a compact console,
yes.
And still a little heavier, but better than all the other things. So that is probably one of the good ones. And eventually, I think there are a lot of other things which are also coming up since AI is there. If there is an AI assisted ECMO adaptation and minimally invasive ECMO, all those things can help. And the last thing would be a telemedicine support. If you can have the retrieval area, you have a telemedicine support and find out exactly what is the ground situation there. It will help you assess the situation very well. And in flight also, or on the transit, in transit, if there is somebody who is guiding the entire team, if there is a complication, troubleshooting, that can help us troubleshoot a lot of complications and help a safer transfer to the hospitals. I think these are probably some of the innovations we can do. Yeah, and flights and all, I am not a very good person to talk about. So
that sums up pretty well. Ravi?
Yeah. So I think,
yes, Ravi, please continue.
Yeah. To summarize, any ECMO transfer, whether it is a short distance or a long distance, we should ideally optimize the patient before we mobilize, plan for redundancies, which should also have their own redundancies, especially when it comes to oxygen reserves, battery reserves, and equipment reserves like IV fluids, even drugs, and carry only the essential monitoring equipment, leaving unnecessary equipments. Power failure is often the most preventable cause, and we should ideally be able to manage it. So coming to our case, so we did a CT thoracic angiography on the same day to identify the possible site of his hemothorax. Luckily, there was no active bleed from it. The patient underwent a VATS and underwent complete evacuation of the blood clot in his left ear. hemithorax. He was decannulated on day 3 and he was discharged on day 5.
Yeah, probably you're showing him in a rehab, getting rehabilitation. Yeah, so this patient had an anticoagulation-free ECMO due to his hemothorax and timely unilateral VATs, and then we could get him off the oxygenation issues, decannulation him, and then yeah, we could get a extubation done. Yeah, so this problem could have been averted if this patient was dealt much more in a systematic way. And yeah, but we had a call and we had to retrieve this patient, and then we were happy enough to get a positive and favorable outcome for him. Yeah.
So Dr. Kadi, so he had a total 8 days run of ECMO without anticoagulation. 5 days there and 3 here.
Correct.
Isn't it?
5 days there and 3 days here. 8 days
Yes.
without
Yeah.
any anticoagulation.
Yeah, very good scenario to explain the transfer, ECMO transfer, because see, this is a guy who had a traumatic injury, was quite unstable. They stabilized him there, and because they couldn't do a thoracotomy and other procedures, once the patient was stable, he was transferred to your place and got the things done. Probably this is how it has to be done. The problem, the you didn't retrieve this patient when the patient was very sick. This patient was stable, and the patient could not have been managed there. That's the reason you got him here. So these are two important points, which is definitely points favoring the transfer for this patient.
Yeah, yeah.
And what was the delta pressures of the oxygenator at that time after 8 days? Was there any increase in pressures? Was there any signs of oxygenator failure at that time?
It was a Centrimax, sir. He was on a Centrimax circuit which they initiated. On day 5 also the delta pressures were acceptable. The P2, P3 were acceptable. There are only minimal fibrin depositions in the clot. Even when we retrieved on day 9, his delta pressures, membrane internal resistance was adequate, sir. We could probably still run the circuit for probably 10 more days, but beyond that, I think it would have needed a oxygenator change.
Very good. So
Yeah.
because this trauma will have a lot of, coagulopathy per se, trauma-induced coagulopathy, and I'm sure he would have received a lot of blood products as per se. So that all can cause a lot of oxygenator impact. So, but it's good, very well managed. Probably you maintained a high flow, and I think we were lucky enough, right? Yeah.
In transit, we maintained around 4.2 liter flow so that we could come off anticoagulation, sir. We didn't know whether it was bleeding or not.
Yeah,
So we maintained high flows during transfer.
Great, Dr. Karthik and Dr. Ravi. Fantastic job.
Yeah, Ravi. Next slide.
Next.
Yeah. Yeah, so this brings to an end of an interesting discussion today, and I'm sure who all have heard today's topic, I think they would take back home few of the nuances that are involved in transporting patients on ECMO, especially from longer distances. We have been practicing bringing patients in ambulances from shorter distances, but the intention of having this discussion was to highlight the genuine problems in the real world scenarios. There are many other problems that we have not touched upon because they were all regulatory problems, and they take a lot of our time and energy when we are transporting these patients. But these are some medical issues that we wanted to deal in today's session. I would like to thank Dr. Himal Dev for taking out time of his busy schedule and having participated in this today's podcast, and even Dr. Ramanathan sir for having joined us on this very important topic, and Dr. Ravi Krishna also, who played a crucial role in transporting this patient in a limited atmosphere and limited resources that he had at his disposal. And we thought this could be discussed at a platform where it could be beneficial for many upcoming centers who are thinking about transporting patients on ECMO. Thank you, Dr. Himal, and thank you for taking your time out of your busy schedule on today's evening.
Thank you, Dr. Karthik. It was a pleasure being here.
Thank you.
with one of the best team. So just wanted to end with so a couple of lines. The long distance retrieval is 80% logistics. It's only 20% medicine. And altitude and time are challenges. And you need to win the battle with a good checklist and good supply of oxygen and battery, and and a good handover that would probably save a lot of worries later on. Thank you so much for this, and have a good day.
Yeah. I'll just try to see. Yeah. Thank you. Thank you all for joining today's podcast as well. And Yashoda will bring many more such podcasts on every Tuesday night. Thank you for joining.